Well, welcome back to another episode of The Compass. I'm here with Dr. Brad Robinson, and today we're talking all things panic, and we're going to get down to the bottom of what is emotions and what is this physiological response sometimes that happens. Maybe, Dr. Brad, we can start with just that 5,000-foot angle view and just say, what is panic to begin with?
Yeah, um, sure. I mean, I think panic. One of the reasons that I thought about talking about it today was the fact that we talked about a couple months back. We talked about transitions with around the graduation season, and we talked about summer vacations and things like that. I can't at all say that there's any evidence to support that panic is more common in the summers, but I do think there's a lot of transitions. So there may be people out there that are just dealing with a lot of the transitions of the summer, which I think does maybe escalate the uh, frequency of panic and panic attacks. Um, and I think, the starting point to understanding panic is to make the distinction between a true panic attack and panic disorder and distinguish that from emotions of anxiety or worry.
Hmm.
And so, to do that, to talk about that, I think we have to um, talk a little bit about what emotions are. In fact, maybe that might be a topic for us at some point, not too far down the road, is just to really tackle that specifically. What are emotions? Um, but, emotions, in a sense, are a part of the mind. That's one way that I think about them. They're a part of the mind that have a function. I think about emotions sometimes as a part of the mind, sort of like crew members on the ship. Our core self, or some people would call it wise mind, is should be the captain. Sometimes it's not. Sometimes the emotion parts take over, but should be the captain. And then these emotional parts are crew members on the ship, and they have a function. So worry, that anxiety part or worry has a function. I often equate it to the radar operator on a ship. It's like that part of the mind's job is to scan the environment for potential threat and to let the captain know, hey, radar's picking up something. There may be something over here. There may be something over there. There's potential threat, and then the captain's job is to assess that and then integrate a response. Um, and so that's one way of looking at what emotions are. Like I said, we can get into that in more detail at some point. Um, but that's one way to think about what emotions are in the context of the mind. But then we can kind of dig into, like, well, what are emotions in the context of the brain?
Hmm.
And the brain is, I mean, that's where we begin to dive into a little more detail of the wiring systems and things like that. And when you look at the brain and try to understand emotion, it's emotions for the most part are in the limbic system of the brain, deep midbrain structures, kind of right between my fingers, deep midbrain structures, and then tons of neural network circuitries that expand out from there and receive inputs from other parts of the brain. And so that limbic area of the brain is where those emotions are at, I guess you could say, in the brain. And then there's a part of the brain called the prefrontal cortex that's responsible for a lot of stuff, but a huge part of what the prefrontal cortex is responsible for is regulating, the limbic system, like knowing, being able to register the emotion, but then down regulate it, not let it get, um, too, uh, over firing, too hot, so to speak. And so those are some of the brain structures that are involved. And so then when you think about panic, and this is part of what I think why it's important to dive into a little bit of a conversation about what emotions are versus what panic attacks are. when you think about panic, a panic attack at its core is very physiologic. A true panic attack at its core is very physiologic in nature. It happens in people, yes, people who have big emotions and don't have very good coping mechanisms and all that can have panic sometimes. That's kind of more of a function of the mind. But most people with panic disorder actually have very, very good coping. Like exceedingly good coping, because many times they've struggled with their, limbic system over firing a little bit. So they've had to really develop coping strategies. So most of the time, people with panic have really good coping, in terms of mind management of emotions and all that, yet have these breakthrough physiologic, panic attacks. That's why a lot of times in my practice, I call them autonomic instability. And somehow
Mm.
that seems to help patients kind of
Yeah.
register that, oh, this really is a physiologic
Yeah.
instability or a physiologic dysregulation in my body, which really does match what the research and the neuroscience suggests. And so then, a way to think about it is that probably it's a dysregulation in that prefrontal cortex
Hmm.
that's supposed to regulate the limbic system, and so it's not doing it smoothly. and
Hmm.
and you get, for random reasons, it may there may be some trigger. For a lot of my patients with panic, it's very hard for them to distinguish a trigger.
Mm.
But for whatever reason, some little something starts the process off. And then,
Mm.
as I often say, it's, your brain, and therefore your body follows suit, is reacting like, the lion is about to eat you. I mean, your physiologic systems start reacting like, oh my gosh, I'm being chased by the lion. It is right on my tail. I can feel the claw, strikes on my back. It's right there. And your limbic system is firing. Your full on, fight or flight response. Your frontal lobes may even know, your frontal lobes are looking around going, well, there's no lion. There's
Hmm.
no, I mean,
Hmm.
there's no lion. I know there's no lion, but the deeper structures of your brain are full on firing
Yeah.
like the lion is getting you, and that's why I really think it's important to distinguish in this situation the brain function that's at work behind this.
Well, it sounds like it would be really freeing for a person to hear that, like,
Yeah,
"Oh, it's not just me, I'm not just making it up, there's actually something
right.
going on." But just as you're talking, and because I sort of had a preconceived idea that it was triggers, and they likely knew what the trigger was because it was attached to certain trauma. So you said something in there that really kind of flipped that on its head for me. Is this biological in nature, or were there factors that happen, like some sort of trauma, or is it both?
Yeah, yeah. I think to distinguish panic, really, I would um, I would definitely lean towards saying that for most people with true panic disorder, it is very genetic, biologically, predisposed. Now, can trauma also be an underlying causal agent through, childhood events and different things, or more, acute trauma? Yeah, absolutely, absolutely. Somebody who maybe doesn't have the genetic predisposition might begin to have panic after a significant trauma, a major car wreck. I've, is one example that I've seen. unfortunately multiple times, but it comes to mind with patients who didn't have that genetic predisposition, but after a major car wreck where there were some family members that lost lives. I mean, those are some specific examples that have come to mind. And yeah, sure. I mean, panic then can be triggered, but there are a fair percentage of folks that come into the office and there's no identifiable trauma along those
Wow.
lines. Maybe the it's more likely that you go back and you look and you start asking mom and dad or grandma and grandpa, and they're like, oh yeah,
Mhm.
this family member, that family member, seems like they did have some, and you begin to realize, oh,
Mhm.
there really is a genetic predisposition going on here, and that genetic predisposition is probably a genetic predisposition for something. I mean, we don't really know 100% for sure. It's not like there's one specific gene, it's probably multiple different genes, but it is probably a predisposition for something in the prefrontal cortex or the limbic system or the communication circuitry between those
Mhm.
two areas of the brain that is just predisposed to
Wow.
being a little twitchy is what I call it. I mean, just a little, it's like, oh, wait a minute, that, um,
Well,
yeah,
twitchy, that person is.
yeah. And that it's so much of what we deal with in medicine is about regulatory systems in the body, right? And so diabetes is the example I go back to a lot. Diabetes is one of those examples where type 1 diabetes is pretty strongly genetically influenced. Certainly, there may be other factors, but if your pancreas if the islet cells in your pancreas just quit producing insulin,
Mhm.
you know, you that's just it. You have to figure out other ways to regulate blood sugar and medicines and things like that. If you have type 2 diabetes, it's more it is probably more a buildup of factors over time in terms of lifestyle and eating and all of that. And if you double down and really regulate those things, you may be able to manage it without medications. So it's similar with panic. There are multiple factors, but I think it's really important for people to understand that just like with diabetes, there really is, and it's not a part of the DSM, but I mean, you could almost imagine for a minute talking about type 1 versus type 2 panic. I mean, I see a lot of folks that truly just have physiologic autonomic instability. Their autonomic nervous system just is a bit twitchy and unstable, and it'll fire off at times like the lion is really right on your heels.
Well, I have a couple. Actually, you made me think of three questions. So let me. I hope I can remember all of them. The first would be: is it on a spectrum? Like, is there,
Yeah,
when you're evaluating it? And then the second would be, and maybe you can talk about this. Um, how quickly can you spot panic in somebody? And is it sort of like they walk in, you're like, okay, I kind of know what we're dealing with. And then the third thing would be: are there any common comorbidities with panic?
yeah. Yeah, it is on a spectrum, and so some people will have a you know mild panic, and or even sometimes a severe panic, and it just happens once, and then they go on their merry way, and they don't doesn't persist. So it is on a spectrum, and with most things that we're dealing with, we're looking at functional impairments. So if it's persistent over time and it is functionally impairing, is when you really start being concerned about labeling it as a disorder and
Mhm.
pursuing treatment. Comorbidities, yes. Uh, yes and no. I mean, it is one of the things that's interesting in my field, in that um the that there is that comorbidity group that comes in with a lot of other life stressors, traumas, lots of things that then present with panic.
see.
But there's the other group that I see that come in with panic, and there's not a lot of other comorbidities. I mean, it is one of those things where, to me, that's one of the things that I think is important for people to understand about panic disorder. For some individuals, it's I guess as I trained in this field and developed my understanding of it, it's one of the things that helped me kind of understand a little more about the pure biology of some of these disorders. Because again, sometimes people come in with panic and it's just panic. I mean, there's
Yeah.
not a lot of other comorbid things going on. There can be. I mean, people can. One of the things that creates comorbidity sometimes is people who wander down paths of trying to self-medicate their panic
Mhm.
with, substances or whatever. That creates some secondary issues. But a lot of times that, there's definitely a component of panic that's just, there's not a lot of comorbidity.
So when somebody comes in, you have it sound like you have two groups of people. One group of people, they just kind of have that genetic disposition that you talked about, and
Yeah.
it seems like there'd be a plan of treatment for that. But if you have somebody that comes in and panic is sort of the tip of the iceberg, and it's a
Yeah.
response maybe to this other stuff, is it case by case on sort of your plan of attack? Because
Yeah.
it might not be the most fruitful, right, to treat the panic when there's four or five other things under the
Yeah.
surface that might be more important.
Yeah, absolutely. I mean, as you develop a treatment plan, with your clinician, I think you want to explore those things as a patient. You want to explore, are there other underlying things? But I think, when you think about, if I have somebody that's coming in with panic, even if there are other underlying comorbid factors, panic itself is so intense and so,
Can you talk about what it's like? How long does it last?
yeah. I mean, a lot of times panic builds up very quickly over a period of a few minutes. It can be a little slower build up, but usually it builds up over a few minutes, lasts. I mean, most of the time it lasts, minutes to maybe 30 minutes. I definitely have patients that would disagree with that, because I have some patients that just feel like they're in a panic attack sometimes for hours. But most of the time it's this quick, sudden escalation. And again, the best way to describe it, I mean, you can find descriptions online. You can, if you've ever experienced it, uh, you know, uh, it's not subtle. Once you've ever experienced it, you begin to realize, oh, wait a minute, that's not just feeling anxious about something. I mean, it is physiologically heart racing, short of breath.
I've heard a lot of
Um,
people go to the hospital because they think they're having a
oh,
heart
they
attack,
think they're
right?
having a heart attack, chest pain, sweating, GI symptoms. You can have, stomach pain, diarrhea. It's all of that autonomic nervous system that's just, full on. And
Mhm.
so it's so disorganizing in that regard and so distressing in that regard that we really do want to try to develop a treatment plan fairly quickly to start helping people suppress that. Because unfortunately, what happens, and that's something we should talk about, unfortunately, for what happens is for people that have had multiple panic attacks, it can start disrupting their day to day life because they begin to, you know, fear having the panic attack. I mean, their body reacts, and then they're
Yeah.
beginning to be like, "Oh my God, is it going to happen? Is it going to happen? What if it happens now? What if it happens in this situation? What if it happens in that situation?" And it can really start. They begin to start constricting their activities. They can become fully agoraphobic, which means that they just don't get out and go because they're afraid that the panic is going to happen in places, work, or at the grocery store, or whatever. A lot of times it starts with wherever it happened at the first time, then you just physiologically try to avoid that place. So we want to try to treat fairly quickly and fairly aggressively. Cognitive behavioral treatments are effective. A lot of times patients that are having pretty significant panic when they come into treatment. They're like, yeah, I've tried that, it doesn't work. Well, because the starting point of cognitive behavioral therapy is, one, just education, helping the individual understand what's going on physiologically, that kind of thing, and then helping the individual learn calming and relaxation strategies. And again, and good cognitive behavioral therapists understand this. We know we're not saying, we're not trying to put a little band-aid on a big wound. We're not saying, oh, just do some breathing exercises and it'll all be better. I mean, most people that have had panic have already tried that, and they're like, well, that doesn't work. Well, it does long term, it does, but you have to understand what we're asking you to do. A good cognitive behavioral therapist is asking you to learn how to play the violin, and you've never picked up a violin. It's like, you can build competencies for self-regulating these heightened, autonomic, activity. You can. It takes practice over time, like, learning to become a concert violinist. I mean, you really have to practice it over time. And so,
It
deep
seems like it'd
breathing.
be something that's very difficult. You have to be totally in tune with yourself, almost, is what it sounds like.
Yes. Yeah. Yeah. And so, good cognitive behavioral therapy, mindfulness exercises, yoga, contemplative prayer practices, things that help you to really be aware and downregulate. Over time, those are very effective. And then you have to pair that with some cognitive restructuring. You have to be able to catch the spiral of thoughts. That part of your limbic system is generating this intense emotion and this intense thought that's like, oh my God, the lion's about to eat me. Your frontal lobes are going, no, it's not. Well, you've got to win that battle between the frontal lobes and the limbic system. You've got to be able to go, no, really, it's not. The lion isn't, about to eat me. So you have to really work pairing the relaxation strategies with the distorted thought and being able to recognize, okay, no, the lion isn't about to get me. I've got to get my mind focused on other things. I've got to down regulate. And then the next phase of good cognitive behavioral therapy is you have to pair, and this is kind of a challenge too, but you do all that legwork, and then you have to pair some triggering events. In other words, you actually have to
face your fears.
Yeah. You have to develop a confidence that I've got a plan. I have a plan. I know how to implement the plan. I can go to the grocery store, and when I feel the first signs of the panic, I can regulate it and regroup. And so that's the essence of a good cognitive behavioral approach to treating panic.
So, and I know that there's probably some frontline medicine or something like that,
Yeah.
but maybe before you get into some of those therapeutics or treatments, can you talk about how somebody would know if it's panic versus anxiety? Because I think that could be confused, or even like adrenaline overflow.
Yeah. Yeah. It's kind of all, I mean, that's a continuum. It's all on a spectrum there, because that, that autonomic hyperarousal is the way to think about it. And it is, I mean, when you activate the autonomic nervous system and that lion, your systems are going like that lion's about to get you. You're activating, the limbic parts of the brain. You're activating, autonomic nervous system outflow to every part of the body, including adrenal glands. You're pumping out the, that kind of adrenaline and cortisol, and you're boom, you're pumping all of that stuff out. So it's all of those things. Distinguishing that from anxiety in general. I mean, anxiety, to me, anxiety in terms of, if you're going to, I guess, make the distinction between worry and more what we would call in the DSM more generalized anxiety, it's more of a buildup over time of increasingly worried about life stressors, worried about things that are going on, and then that builds and that builds and that builds and that
Hmm.
builds, and then sometimes it can, lead to panic. But it's a much broader, intrusive, ruminating worry about life stressors that's hard to physiologically downregulate, as well as emotionally downregulate. So those are some of the things that you're sorting through at that point. And then as you mentioned earlier, like, what's another thing that's hard to distinguish? Well, you know, for my patients, I mean, if I get a call from, a patient, or we get a call at the office from somebody that's, first time having sudden onset racing heart, chest pain, all of those symptoms. I mean, the first thing I'm going to do is make sure they're talking to their primary care provider, or they're going to the emergency department. I mean,
Hmm.
you do, there's
You got to know
not
what
an
it
easy
is. Yeah.
way, there's not an easy way initially to distinguish, if you, especially if you're at an age and have other risk factors for heart issues or whatever. There's not a real easy way to distinguish other than just having a cardiac workup. And,
So
not everybody that has panic needs a full cardiac workup, but I'm just saying, you know, at some point, you need to talk to your primary care doctor, or if you're having acute symptoms, you may need to go to the emergency department and just have some basic labs and an EKG, and make sure there's not any, clear signs of cardiac workup. And then if there's not, then you don't have to keep going back to the ER every time you have one of these things. You begin to kind of realize, okay, this is panic. I got to figure out some other ways to deal with it.
So when you do sort of lean into the medicine, at what level, when does that happen in the journey? What types
Yeah.
of medicine do you recommend?
Yeah. When people are having the full on panic, I think it's important to do the cognitive behavioral therapy, because the data suggests that you're going to get better long term results with good cognitive behavioral therapy than you are with medications. But sometimes it's a challenge to get things suppressed quickly enough for the cognitive behavioral therapy to be effective. And so that's where medicines come in. And SSRIs are the first line treatment. And then sometimes combined with short term use of benzodiazepines. Benzodiazepines are potentially addictive. There's definitely got some abuse potential. But I mean, there are, lots of people with panic that don't overuse or abuse benzodiazepines, are able to get off of them very easily once their panic is better controlled. Um, and they do help suppress. The thing that helps keep somebody from getting kind of addicted, I guess you could say, with panic, to benzodiazepines, is that they really do the work of the cognitive behavioral therapy, and do the work with um, with the SSRIs. So you combine cognitive behavioral therapy and SSRI, short-term benzodiazepine to suppress the acute nature of the panic, taper off the benzodiazepines over a period of a few weeks. That's ideally the best way to approach it. And many times it's a very effective treatment. It's very effective treatment. This is one of those things, Tyler, that, I mean, my practice, I built my practice on building long-term relationships with my patients. I see my practice as primary mental health care. I want to be here. I want our staff to be here for people along their journey throughout their life, dealing with the ups and downs of life stressors, developmental issues for kids, a lot of complex, biopsychosocial issues, trauma, all that. But panic disorder is one of the things that I mean, I see people with panic disorder that I've seen for a long time just to kind of help them out with their medicine management. But panic disorder is one of those things that, I mean, if people come in with panic and they get that combination of treatment, you know, treatment success is high, and they learn how to manage it, move on, without a lot of difficulty. So
That's great. Well, I found this very fascinating and actually gained a lot of compassion for folks that are dealing with panic, or you call it autonomic, what'd you call it?
yeah,
Instability,
yeah,
autonomic
autonomic dysregulation or autonomic
dysregulation.
instability. Yeah,
Yeah.
yeah.
I mean, when you hear about it, it just sounds heartbreaking for people that are having to deal
Oh
with
yeah.
it. And hearing you talk about just some different techniques to get them on the healing journey sounds great. So I encourage people to be able to do that. You have any final thoughts you want to share?
I I think just like I said, yeah, get get treatment. I mean, don't if you're having some of these sort of things, seek out some treatment, because it's one of those things that, I mean, we at some point may tackle sort of guys in depression, guys in anxiety disorders. We may talk more about that. I mean, guys are bad about, I mean, that's pain with a broad stroke. Sometimes, ladies are also don't always come in for treatment, but guys are pretty bad about just, white knuckling things out and saying, oh, I'm just not going to. Well, I mean, great. I mean, if you have one panic attack and then you white knuckle through it and you don't have any more, okay, fine. But if you're finding it where you're having, ongoing episodes of this panic, come in and get some treatment, man. It's, if your pancreas quits producing insulin, you got to get some treatment. I mean, it's just part of it. If your, PFC, your prefrontal cortex and limbic system are just out of whack, it's just a part of your brain that you got, just come in and get some treatment. Don't make it into something bigger than it really is.
Well, that's great. And if you're interested in contacting us further, you can call 573-334-7055. You can go to our website, bradrobinsonmd.com. And thank you so much for tuning in for another episode of The Compass.